services and mental health services. So this is one of the global factors. Greg Ahrens, Mike Hurlburt, and Sally Horwitz are colleagues of mine at one of the NIMH-funded implementation research centers that I work with in San Diego. And they propose that there is an outer context with a service environment. That would be, the state, county regulations, the particular service mix and number of providers in a particular community. The inter-organizational environment is how do those different entities within the community or community and state interact with one another. And the bottom box on the outer context is the consumer advocacy and support groups that might exist within that context. On the far right is the inner context within any organization that's actually providing mental health services. What are the characteristics within the organization? There's been some good research on that I'll talk about in a moment with respect to organizational climate and culture and leadership and resources. And then there are the individual adopter characteristics, clinicians, paraprofessionals, consumer helpers, things that within the organization at the individual level that might affect implementation. There are interconnections in any particular evidence-based or other innovation. There are interconnections between the outer and inner context, between the ways in which the innovation itself fits within the organization and within the broader service system and its characteristics. And then there are the intervention developers and the characteristics and the protocols that they have put into place. And all of these things presumably could affect client outcomes. A model for implementation science that has been put forth just to help folks understand how it might be different from treatment research or just services kinds of evaluations is presented here. Again, some of the same cast of characters that wrote the last piece, produced the last diagram. And so the white box is an evidence-based practice. Pick one, anyone. Could be at the treatment level. It could be at the organizational intervention level. Evidence-based simply meaning that it has been demonstrated to be effective in meeting its goal in at least a few rigorous studies. So you have those. Then there are a variety of implementation strategies to try to get that practice to be implemented in a practice context. Those include the systems environment, about which there's fairly little research, a fair number of case studies, but not really any rigorous research about if you change X or Y thing at the system level, how does it affect what happens within organizations and in the implementation of the treatment. So I won't be talking about those kinds of strategies today. I will be talking about these that are asterisked and in red, bold font. So organizational factors and organizational strategies can be used to help implement an evidence-based practice. Group learning and training kinds of interventions, strategies can be used. Clinical supervision, and then strategies, a variety of them that focus on individual providers of the intervention and consumers. Presumably, those things would affect then the implementation outcomes. There are several implementation outcomes that are proposed, and they differ from a service outcome. An implementation outcome can be feasibility. How feasible is it to get the thing into place? Fidelity to the actual intervention. Penetration, how far can you spread the intervention? Acceptability, how acceptable is it at the level of the consumer, provider, organization? Sustainability, when does it get its own legs and keep going? Uptake, which is a little bit related to penetration, and so I think should have gone up there earlier, but I think the point is how much of the uptake do you get, and then costs of implementation, which in turn can affect the efficiency, effectiveness, and so on of the treatment once it is, or the innovation once it's happening in the real world. And then you get to the client outcomes also, which are really have folks functioning and symptoms been improved. I'm going to today now focus on a particular set of strategies that are asterisk that have been used and researched. And before I do that, just want to point out that there is an understanding, much of it from case studies in other fields like business, agriculture, technology, education, some of it from human services, that the implementation process is one that is probably phasic. research is now starting on what do those different phases look like and how can you affect them. I'm going to be talking today about strategies that have been used and researched specifically in the active implementation phase and the sustainment phase. At the end, I will also mention that there is currently research going on to find out, in fact, whether implementation does occur in phases and what those phases look like and whether you have to do one of them before you do the next. But I'll be focusing today mostly on active implementation. So before I talk about the particular strategies that have been researched, I will pause now to see if folks have questions about what I've said so far.
I don't think we have any right at the moment. I am waiting for one to come in via our questions pane because we had a raised hand. So go ahead and keep going, and I'll let you know if that comes through.
Thank you very much. All right. So one strategy for trying to implement a new innovation is training. And with respect to training, what I'm presenting here actually with each of these strategies is information that I've gleaned on the basis not only of the research that all those groups on my second slide have done, but also on the basis of my reviewing of a variety of both quantitative and qualitative reviews, meta-analyses, and just qualitative descriptive reviews of the literature on each of these different kinds of strategies, including training. And so based on those reviews, there's some fairly clear consensus that you can, in fact, reduce variability in provider behavior and improve fidelity to a particular intervention and increase service delivery quality by providing training. The question is, what kind of training and what kind of settings, what does the training need to look like? What do the support conditions need to look like in order to get this promise that training could offer of getting more consistent provider behavior to implement evidence-based practices with fidelity and increased quality? And there is, with specifically regarding evidence-based treatments, psychosocial treatments, that research is beginning to build. There are a number of reasonably good studies out, but it's still in its relatively early stages. And so some of what I'll be talking about is what had already been learned about this kind of training from other kinds of research on adult learning, adult education, professional training in other contexts like medicine and literally education, training teachers. So what would evidence-based training look like? Harold Stolovich was the director of the American Society for Training and Development and has this declaration that telling ain't training and training ain't performance. And all of us here on this call probably already knew that, but it's nice to get a pithy reminder now and again. Performance-based training, that is, if you really want someone to engage in behaviors at the point of the work they're doing with their clients or with other clinicians, that's a different thing from just training to get to know knowledge, right? So knowing is knowledge acquisition. You have to provide an opportunity for people to increase their knowledge about a particular innovation if you want them to implement the innovation, but it's not enough to actually do the thing at the point of contact. Knowing how to do something is skill acquisition. Training needs to build that in. You have to know the thing. You have to know something about knowing how to do the thing. And then you actually have to do it at the point of performance. And so performance-based training, where really the endpoint is getting somebody to do a particular thing with a particular client tomorrow, requires deliberate practice, experiential learning, feedback, and support. We do know from research both with physicians in medicine with evidence-based implementation of evidence-based psychosocial treatments that one-time workshops can in fact increase knowledge and attitudes but doesn't change behavior. So there are a number of studies about substance abuse treatments for kids. If you show clinicians, tell clinicians in a one-time workshop about contingency management, their knowledge increases, their attitude about its use increases and becomes more favorable, but it doesn't enable them to be able to actually do the contingency management, for example. In order to build proficiency, there has been one estimate that, it may take 20 to 25 implementation attempts for professionals to change their behavior and incorporate competently a new set of behaviors. And the different approaches to doing that have been recently reviewed include academic detailing, which is an approach that the pharmaceutical companies and companies that do prosthetics like hip replacements and things like that have really mastered, and there have been a large number of randomized trials. And really what academic detailing is having essentially a representative who knows very well the pharmaceutical or the device come in and actually show physicians what it is, describe the properties of the thing, show them how to use it, check in on them periodically that they have used it, and that a number of randomized trials has showed that really does help physicians to be able to do the new procedure, use the new drug according to the appropriate dose, or use the new hip replacement device and surgery appropriately. Coaching is something I'll talk about in a few slides from now. Interprofessional learning is something that has only a few well-designed studies, and what this refers to is, for example, if you have doctors and nurses and physician's assistants all together as a team trying to learn something, or you have a therapist and a consumer aide and someone else trying to learn together how to do a new innovation, a new practice. And the evidence here, again, few studies, it looks like it changes the knowledge and attitudes and communication across the team. So doctors, nurses, physicians, assistants communicate better with one another, but it doesn't look like it changes practice behaviors all that much. So there may be something about the way the team works together and communicates that is improved. It's not clear that translates into better care at the end of the day. The evidence is just too mixed, and there are too few studies. Reminders, these are just, those things that tell us, if you use Outlook and you happen to have on your calendar that you were supposed to attend this call today and you got that 5 minutes before the call, that's a good example of a reminder. Lots of randomized trials showing how reminders at the point of the practice helps folks to do their jobs better. Self-regulated learning, right at the moment, very little research. So far, most of the research has happened within medical schools and residency programs, and this is basically trying to an approach of seeing if you can, on your own, titrate what you're learning and how you're learning it, and sort of test yourself as to how you're doing. And so far, again, it looks like people's knowledge of the practice increases, but changes and their attitudes and skills change a little bit, but they don't really then translate that into practicing differently. And problem-based learning was also something that was done first in medical schools, giving people the diagnosis of the patient or the patient's symptoms and saying, now, given what you've learned, and what we're going to learn together, what do you think the problem here is? And that one has had very mixed effects, and so what medical schools and residency programs have done is reintegrated that into didactic learning so that people essentially take turns learning the knowledge about something and then seeing the problem and seeing if they can solve it rather than trying to intuit their way to the knowledge from the problem in front of them. Coaching and consultation is something that's been around for a long time in a lot of different fields. One of the types is expertise-based, so the person or persons who have expertise in a particular topic provide coaching to those who are just trying to learn the topic. That has taken place in a number of different industries. Peer-to-peer coaching is something that was very common in education. Teachers, sort of the master-teacher idea, where teachers observe one another and then give each other feedback. They may be at the same level. Actually I misspoke. If it's really a master teacher, that may be a person who's considered to be an expert-based consultant. The evidence is very mixed about the effects of peer-to-peer. Again, it looks like good cohesion building, not clear it changes people's practices. The kinds of approaches that people use, the methods they actually use in doing the coaching and consultation include providing direct feedback following the observations, reflecting on one's own practice, which is sort of like the self-reflective training that was on the prior slide. I'm suggesting that there may be an emerging type of coaching and consultation, and it is one that is sort of emanating out of the work that is happening with the transportability and implementation of multi-systemic therapy, and also with other treatment models such as multidimensional treatment foster care and functional family therapy, in which folks who have been trained to do the treatment and then have supervised folks in doing the treatment ultimately get trained also to become the experts, and so they are peers with the therapists and supervisors in some ways because they've had that experience, but they've now been trained up at the expert level. The nice thing is that within the last 10 years, there has been an increased use of sort of expert-based coaching examples within psychosocial treatment rather than just medicine or teacher training. Here are some of the different types of treatment for which that coaching has been done. There has been little research on the effects of that coaching for TFCBT and parent-child interaction training, although some good descriptive case studies. We have some findings that are published on what the effects of consultation are and adherence to the consultation protocol on therapist adherence and outcomes for multisystemic therapy. There is one study underway for peer coaching with the PPP Positive Parenting Program that's trying to evaluate the advantages and challenges of using just peer support groups and rather than an expert consultant, and the jury is still out. That study is still ongoing. We don't know a whole lot yet about all of the specific strategies, mechanisms, processes in consultation that are enabling folks to sort of improve the implementation and outcomes for the folks who get the consultation. But these are among those that have been examined in a qualitative review of consultation studies. So engagement, the coach being able to engage those, say, therapists and supervisors in the interest and implementation of a particular practice, helping therapists and supervisors to problem solve implementation barriers, applying the specific coaching strategies and advice to cases, helping people to know what kind of adaptation to the intervention is acceptable and how to make those and what is not, supporting accountability, helping people to skill build and to sustainability plan. There are a couple of studies ongoing that I'll just mention, that one done and one ongoing that are trying to get a better job of an evidence base, putting an evidence base about under consultation. Again, Abe Wandersman and his colleagues did a review and found that dosage, delivery method, collaboration, and proactive consultation seem to result in better effects of consultation on the implementers. There is, again, less known about the specific functions that we just identified before, about how it is that those things happen. And then there's a study underway that Shannon Wiltsey-Sturman and her colleagues are doing that I think will help shed some light on which processes matter when. With trauma-focused cognitive processing therapy for veterans with PTSD, there's this randomized trial of 3 different conditions of consultation that vary a little bit with respect to their delivery method, in other words, whether it's live with the people doing the implementing or by phone long distance. The dosage is being varied, but some of the same strategies are being used across all of the conditions. And she'll be able to link the different coaching mechanisms with adherence, competence, and improvement in client symptoms. So that's very exciting work that's now ongoing. Before I move on to clinical supervision, do we have any questions so far?
Nope, not yet.
Okay. So clinical supervision, what is it? How do we know if it's effective, I guess, is one question. And one way to tell is that it actually affects clinicians' behavior. Another is that the change in behavior ought to translate into effects on client outcomes. And a research review of clinical supervision studies that was done in 1997 found, first of all, that there only were about 10 decently designed studies, rigorous enough to test the effect of supervision, and found that at that time, none of them actually ever looked at the effects on client outcomes. And so Ellis and Ladney had suggested that really the acid test of good supervision ought to be that it shows up in improved client outcomes. So there are several different studies that have been done in the substance abuse field by Hannah Knudsen and her colleagues, and then some studies more recently in mental health services that Greg Ahrens has done with colleagues that has shown that that the combination of coaching, that coaching strategies within clinical supervision. So this is a little bit different from the last several slides about coaching processes. This is actually within the clinical supervision. So there is a clinical supervisor directly responsible for providing support to therapists within the same organization in a sort of standard clinical supervision format. So some of the benefits that have been demonstrated in the substance abuse field are that there is decreased emotional exhaustion and decreased intention and turnover among substance abuse counselors when there is clinical supervision that has some elements of what I'm going to discuss next as sort of the components of that supervision. It's also the case that there is decreased turnover among mental health services staff who've been trained to do evidence-based interventions who then get clinical supervision in those interventions. There are there's some additional old news from research that was done that I did on the transportability of multisystemic therapy. And so I'll only briefly go over it since it is old and has been published in a number of places and presented by a number of people. The first study on clinical supervision that we did was a 9-site pilot in which we were just trying to develop the measurement tool to use to assess the nature of clinical supervision in MST. And we were able to do that with input from clinical supervisors that we had trained in different sites and base that measure called the Supervisor Adherence Measure, or SAM, on our clinical supervision manual that Scott Hengler and I had written. Subsequently, we were able to, once we got the evidence of reliability and validity of that supervisor adherence measure, we included it in funded studies, study funded by the National Institutes of Mental Health and then subsequently National Institutes on Drug Abuse, on the implementation and outcomes of multisystemic therapy in 43 different sites. And out of that, I'll show you one slide about the supervision findings specifically in a moment, and another slide later in the presentation about all the connections between adherence at different levels of the practice context and outcomes that we found in that study. Really exciting new news about clinical supervision and evidence-based clinical supervision comes out of something called the Child Steps Project that was funded by the research network, that was funded by the MacArthur Foundation, and I am an investigator in that group along with John Weiss and Bruce Chorpita and a number of others who were the co-principal investigators. And this is a group of projects specifically designed to see what it's going to take to get evidence-based treatments to be implemented effectively in usual practice settings. And in the context of this group's work, there were randomized trials, multi-site randomized trials, testing the implementation and outcomes of treatments for kids aged 7 to 12 who had either depression or anxiety or conduct disorder or some combination of all three. And one of the primary research questions in that study is it essentially more effective to do the standard manualized treatments that had been shown to be effective in randomized trials one after another for those kids, or is it better and more effective to be able to use different modules from each of those kinds of treatments for kids who have, for example, comorbid anxiety and conduct disorder, using a very specific algorithm and treatment and training process. So in the context of that study, we also looked at supervision. What was it going to take to supervise these? These were community-based clinicians in community-based clinics to be able to do these different treatment approaches. And so we took the opportunity to do a prospective observational study of supervision. So we didn't manipulate it. It wasn't randomly assigned to either get supervision or not. This was just observation of the supervision processes used to help people to implement. And what we found, whoops, I'm ahead of myself. So let me pause there and tell you that we're going to move back to the old news for a second, having just primed you all for the new news. That, by the way, is a very ineffective training technique, and I would recommend not doing it in the future. Back to the old news for a second, already published, and so won't make much of it, but we did find that we have 2 of the 4 supervisor adherence measure scales predicted in MST, 1 year post-treatment change in youth behavior problems. 1 of the scales also predicted therapist adherence, and we found direct effects of both supervisor and therapist adherence on kid outcomes. With respect to long-term criminal charges of kids levied against kids in this study, we also have this beautiful slide that basically says that clinical supervision predicted that one of these particular subscale, structure and process, the higher the scores on the structure and process, the less likely kids were to be rearrested between 2.4 and 4 years after treatment had ended. So now I'll go back to the exciting new news and say a little bit more about what we're finding in this MacArthur-funded work. And this won't come as a surprise to you either. It's always interesting to me, though, that we tend to know that we need to practice more and do more behavioral things and do more performance and get feedback. But instead, we seem to find ourselves talking, and of course, I'm talking now, and so I'm guilty of this as well. None of us is going to be able to walk out of this webinar and do anything differently because I'm not doing anything to help us practice. I'm just talking. So the community-based therapists were trained in these specific EBP protocols for anxiety, depression, or conduct disorder. They were supervised by doctoral level supervisors with expertise in those models. They were doctoral level because they were part of our MacArthur Research Network group. There were 136 youths and families, and what the very reliable observational coding system for this supervision model found were that the more you got therapists to do modeling and role play in supervision, the more likely they used the actual treatment, the treatment module in their cases. So better to show it and do it and role play it than talk about it. That was also true for just modeling alone, even without role play. Clinicians were more likely to use the particular treatment technique in their next session. Interestingly, there were greater effects for older clinicians who had been out practicing for some time and were just aged chronologically older than there were for younger clinicians. And sort of counterintuitively, there was this finding that that discussion actually did predict greater use of a new intervention by the male therapists. And that sort of was ironic because there is this old stereotype that the men think that, too much talking is just not useful. And in this case, talking seems to have helped them to do the intervention. However, there were only 18 of them, and the finding is a little bit tentative. So mostly support for modeling and role play, and also really good news that even for older clinicians who've been practicing for a long time, it was helpful to have the opportunity to do something differently in supervision, model and role play, rather than just talk about it. There's a study right now that Shannon Dorsey and her colleagues are doing in Washington State, in which, as a state had its mental health agency put out, sort of attempt to disseminate trauma-focused cognitive behavioral treatment, TFCBT, for children who had been referred by child welfare systems to mental health for possible abuse and neglect. So the state undertook training across a number of state public mental health centers, and Shannon is taking the lead in this study, in which she's first trying to see what is it that supervisors in public mental health settings generally do in their supervision of therapists who are seeing these kinds of kids, and then to using the TFCBT once they've been trained by the state, and then to take a look at constructing supervision so that it includes elements from efficacy trials of TFCBT, like session review, model fidelity, monitoring, skill building, and behavioral rehearsal. And in her randomized trial, the supervisors in both uses symptom and fidelity monitoring. Symptom symptoms of the kid and fidelity to TF-CBT. And then in one of the supervision conditions, supervisors will also get behavioral rehearsal and supervision. And her study will tell us, did that matter to what the supervisors did, and does that matter to what the therapists do and what the kids get at the end of the day? Pause there for a moment. Anything I need to address before moving on?
No, it looks like everyone's just attentively listening. So no questions as of now.
Amazing.
No. No, you're doing a great job.
So the next kind of strategy that has been examined in the research is essentially our feedback strategies. So separate from whether you've ever gotten training or whether you've ever gotten coaching or whether you've ever gotten clinical supervision, feedback, just what is the function of getting feedback, is a question that has been asked in a number of fields over time. And within healthcare, this has been a subject of research for a good 20 years or more. And there's something called an audit and feedback system. This simply means that your behavior is audited. This is not the IRS coming after you on April 15th. This is just audit at meaning monitoring what behaviors are engaged in and giving you feedback about those behaviors without any other kind of intervention. And there's a really great database, lots of good randomized trials in healthcare about the use of audit and feedback systems to support physician implementation of evidence-based guidelines, from everything from prescribing practices to procedures for things like hip replacement, to hand washing, what used to be hand washing and is now basically just using those the alcohol-based cleansers from dispensers that are placed throughout hospitals. And so on the basis of reviews of that research that Jeremy Grimshaw and his colleagues have done and Jambet have done, the bottom line from the meta-analyses and qualitative research, qualitative reviews, is that these are really pretty effective for fairly straightforward tasks like hand washing, putting tools, surgical implements in exactly the same place on a tray each time, and for very prescribing practices for very that are fairly where you don't have to follow a complex algorithm. They are also more effective for physicians who had low baseline adherence to those practice guidelines than for the physicians who were already adhering pretty well. So that's useful to know in terms of targeting the audit and feedback systems sort of in the most cost-effective way. So if you can get a baseline on how everybody's doing with respect to implementing a particular thing, and you get to the physicians who aren't doing a very consistent job or a very good job implementing it, if you target these audit and feedback systems to them, you get great bang for the buck. In addition, however, particularly even for straightforward tasks, the feedback that they get has to be fairly sufficient, and they have to get sufficiently detailed, and they have to get it pretty often. So the feedback array that they see has to tell them, specifically with these 4 clients in these 3 days, you did not use this specific algorithm for this disorder. So that is, as opposed to just saying you did it 4 out of 10 times, or not knowing which clients you did it with or which conditions you did it with. The research on using such systems in mental health or behavioral health is relatively new. There are fewer studies, and fewer of those studies that exist are rigorous. But it's looking pretty good so far. One of the studies that worked that has done this is in the context of a randomized trial is one that John Lockman and Carolyn Boxmeyer and their group did on the coping power intervention to prevent sort of aggressive and violent behavior among sort of upper grades, elementary school and middle school kids, using the coping power treatment program that John and his colleagues had developed. And in the context of field testing that, taking it out to more schools, actually a large number of them across Alabama, they found that if they could give the school-based providers feedback about their fidelity to coping power, doing that enabled those providers to improve fidelity and outcomes even without a lot of other support. So they still continue to get some supervision, but when the supervision included this fidelity background, this fidelity feedback, those providers did a better job then of higher fidelity subsequently and getting better outcomes than the people who had the supervision but didn't get the benefit of that feedback. Len Bickman and his colleagues also have a large randomized trial testing what happens with just community-based clinicians doing a variety of outpatient treatments, and found that when clinicians got standardized feedback on valid, reliable measures of progress and outcomes weekly, they were able to get better improvement in the kids' symptoms subsequently. So there is something in there for us to pay attention to. And that has led several researchers to suggest that in order to go from just this practitioner feedback to some kind of system that can really support implementation for therapists, supervisors, other folks in the organization, what we really ought to do is to try to use implementation feedback systems that can support the reach, the quality, and the sustainability of evidence-based treatment. So going from just a simple action effect feedback to a single clinician to a more complex process where you can get indicators at multiple levels of implementation and figure out from those indicators, gee, if it isn't being implemented well, then, where does the problem lie? And in order to have those work well, so one of the things those systems can do is it can help us distinguish closer to real time if the reason we're not getting outcomes we're expecting is because the implementation process is problematic or the actual innovation, the actual treatment isn't working for this population. There's often confusion where there's a sort of experience of you don't get the outcomes you're expecting, and so since you paid for program X, you assume program X doesn't work for that target population, when in fact the problem may be program X really does work, but it was not implemented properly. And so this confusion between treatment failure and implementation failure is something that a well-constructed feedback system can help to address. It enables us to tell the difference between whether there's a problem at a practitioner level that requires greater support or at the level of organizational policies, procedures, leadership, climate and culture, and so on, or at the service system level. Presumably, such a system could help support sort of a learning organization process and culture. And it also provides all the implementation folks sort of a similar yardstick of accountability. Everybody can be looking at the same thing, whether it's the payer or the CEO of the provider organization or a clinician, and say, oh yeah, I can see what the problem was and where it lay, and therefore we can figure out better what to do about it. To get there, you've got to have meaningful, valid data. That raises issues and challenges in and of itself. Some things, what is it you want to report on? Some things are, you can just count, session attendance, service use, did the client come or not? The other things, other kinds of targets that would matter in these kinds of systems actually require using or developing and testing instruments that can measure the thing in a valid and reliable way. So engagement is something you actually have to have a measurement that can get you there. You can't just sort of get an impression and say, yeah, I think they were engaged and that works for me. Same thing with fidelity indicators, symptoms and functioning, and organizational constructs. There are questions about when you actually have to get these data, and then how to use the data that you've obtained. So if changing behavior, for example, if feedback to the practitioner, if you want that to happen and you want that to sustain the behavior they're doing that's appropriate, or you want it to change a behavior that needs to change some, then you have to have evidence that your indicator actually changes on the basis of feedback, of behavioral change, and that the behavior will change in response to feedback. So one example that I like to use for multisystemic therapy is some of our adherence measurement instruments are reported on. For example, therapists report on a supervisor every 8 weeks. So if you wanted to use that feedback to change a supervisor's behavior tomorrow, that would be pretty tough because your measurements are 8 weeks apart. So all we know is on average over 8 weeks worth of supervision. Here's what the supervision looked like, and so we may be able to change it for the next 8 weeks, but we wouldn't be able to use that same measurement to say, here, if we give you this feedback, we want you to change it tomorrow. The measurement method wasn't designed to detect or to create changes on a day-to-day basis. Finally, these kinds of systems in and of themselves are sort of implementation experiments, and being able to design the data collection, get it into an array that end users can understand it, and then see whether it helps you to implement your entire, implement any number of evidence-based interventions is something that we have little research on at the moment of how best to do that. This may solve the problem for all of us. I did not get paid by these people to put this up here, but it's here just to say that there are some practical tools and resources we may need to look to as we design and test these kind of implementation support systems. And I'm going to move quickly into talking about how some of these support systems are being tested currently in research. Let me pause for a second because we've just got 10 minutes left and see if there's anything that folks have asked so far that I should be aware of.
Yes, we have a list of questions, and I'll just kind of brief you on them, and you can decide what you'd like to take time for. How's that sound?
Great.
Okay, so David would like to know, what are the costs associated with these types of fidelity assistance, and what percentage of an initiative's budget should go towards that? And I'll just read through the questions, and then that way you can decide, what you want to take time for. Yep. Frank would like to know, what can we do to change graduate education to get students to be more accepting of evidence-based practice when they get out into practice? And then we have a comment from San Francisco Community Behavioral Health. They say they're in the process today, in fact, of meeting with their psychologist to get buy-in and prepare them for a new role as peer experts in their clinics. They say that on the child side, they're likely to use MAP, but would like to know, or actually said they know that they have to start with this buy-in process to get their input about what they think are their unique competencies.
Oh, Jennifer, I lost you.
Oh, you lost me? Can you hear me now?
Jennifer, I can't hear you anymore.
How about now?
Yep.
Okay. So back to San Francisco Community Behavioral Health. They're starting this process. And on the child side, they're likely to use MAP, but know they have to start with the buy-in process to get their input about what they think are their unique competencies and skills. And so she'd like to know if you have any thoughts about how to move from the buy-in process to adoption of this new role. And then we have one other question after that. Does implementation science help advance EBPs nationally? Are there policy implications of your work?
Okay, so let me see if I can go in the reverse order for a moment and then acknowledge that in taking some time to talk about these questions, I'll end up just skipping over a couple of slides quickly. And we
can also skip our polling at the end too. So
okay.
And we'll just go until it shuts us down. How about that?
So the issue of having of what's happening in San Francisco, I happen to be in Moraga right now, actually, which is only about 20 miles from San Francisco, so I just pop over to the meeting if you would like. But actually, I can't do that. But it's great that you're paying attention to the fact that you'll need to get folks to who are supposed to be doing the implementing get their feedback on what they think they already do well and how the new thing they're supposed to do might fit with that and what might need to change. So there's great sensitivity. And the earlier in this presentation, what I said is that I would not actually be talking much about the phases of implementation that have to do with first trying to inform people about a new practice and then get them to try to make the adoption decision. So some of the strategies for adoption, trying to get people to make the adoption decision, are things that aren't the focus of this presentation. I'm focusing more on sort of once the implementation decision has been made, what strategies do you use to get it to go well and to be sustained. That said, strategies that focus on adoption have to do more with sort of involve some things like motivational interviewing, in which you try to get folks to see what practice they're currently doing, what are the objectives of that practice, are they meeting those objectives. It's often helpful to show them data that they either are or aren't meeting those objectives, and then to try to get to tailor to the folks that you're talking to the messages about how it is likely to benefit them and those they hope to serve if they do this other thing. You then have to actually provide them the training and the support to do the other thing and the feedback to show them when they're doing it, what happens that goes well, and when they're not doing it, what might the cost be. And it needs to be some combination of qualitative and quantitative data. So it's great that you're attending, and that's about all I can say about that at the moment. The question about what are the costs associated with the implementation support strategies, depending on the strategy and the different treatment that it is being used to implement, there are cost estimates that for some of those things that have been published, and it right now is at the level of specific to a particular intervention model. And so also the purveyors of those models have the information about what the cost is of the implementation support. There is not yet a generic cost that says, across the board, here's what it costs to do, to do audit and feedback systems generically for physicians doing prescribing versus for therapists who are doing PCIT versus for substance abuse folks who are doing CM. So right now those costs are intervention specific, and not everyone has yet from their research been able to publish what the costs are. Is it happening nationally? It is increasing. The national, some of the federal agencies that provide service dollars, not research dollars, have begun increasingly to keep lists and to encourage, like SAMHSA and places like that, to encourage the implementation of evidence-based treatments and to provide some funding for people to pay for implementation support. But it is, and the Healthcare Act for Comparative Effectiveness is, I think, going to continue to put a premium on folks using evidence-based interventions and getting support for its implementation. The same is happening in education, but has the tipping point come so it is happening nationally? No, I don't think so. And I missed one, but I think I probably need to spend a few minutes talking about these multi-component implementation strategies. So if it's still out there when I'm done, I'll try to answer it then. How about that?
Sounds good.
So in the event that this Dashboard Dummies book doesn't solve all of our problems in a moment, I just want to point out that this thing about getting measurements that are meaningful to folks in a feedback system varies according to the purpose, the objective of your measurement and what you're trying to accomplish. And so some dashboards, we've got little babies who really just need to be, be fed and be dry and be sort of loved and have some fun. You can end up with a feedback system that looks something like this. You just need to know about their diaper, their tummies, and their energy level, and whether or not they need a nap, and we all might need one by the time I finish this talk, I would say. So that's fairly straightforward. On the other hand, here's an example from a MacArthur-funded Research Network Child Steps trial in which I just want to point to a couple of things. One is that some of these data, like child internalizing, parent internalizing, and CBCL, those are valid, reliable measures where somebody had to go out and collect the data, somebody who wasn't a clinician because it could bias what they get. Whereas others of these things are just events. Did the clinician use the fear ladder? These are elements of evidence-based practice for the anxiety. And so you can end up with something where you can see the progress across the board on just count, and you can see events. Did the therapist do X or Y thing? And then you also have scores from valid and reliable measures. So this is much more complicated, but it is something that the supervisors were able to see for each clinician, and then the clinicians were able to use with respect to which elements were they using and what got in the way of using them for any particular session. Essentially, the putting together feedback systems that include quantitative data have to take into account what is the purpose of what you're doing, and then are the measures effective, meaning are they reliable and valid, and are they efficient? Can you use them? What's it going to take to use them in real-world contexts? And the citations here expound further upon what one might do to make those two things come together on behalf of knowing you have really good, reliable data and can do something with it that helps to improve practice. I want to take just a couple of minutes now to say that there are, in fact, so these have been the different, I've been sort of these little puzzle pieces on the left-hand corner have been, I've had a different color for training versus feedback systems versus supervision and consultation. If you put these all together, you get essentially multi-component strategies that address different levels of the context. And their objectives vary. There are several of these. Some of them are now being tested in randomized trials. But essentially what they are attempts to systematically address the service system and organizational context and then clinician and supervision kinds of things that have to go on to get, that may be needed to implement a particular practice. And to the question of, how do you talk the psychologists into doing this, as I said earlier, some of these strategies are focused more on helping people to make the adoption decision. So first telling them, gee, are you even aware that this particular thing exists, and how might it be useful to you, and so on. So we haven't talked much about that. That sort of is a thing of sort of an enterprise in which you first have to make those who are unaware aware that something exists, and then you have to try to motivate them to see that it could be in their best interest and the best interest of those they serve to learn a new thing. What we've been focusing more on is sort of supporting implementation fidelity at the level of the provider and the organization and service system, and then seeing if you can build the capacity to do that at the larger scale. As I started the earlier slides in the presentation, suggested this can be happening in several phases. There could be specific objectives to specific phases. Getting somebody to make the decision has to happen first before you can get them to actually implement. And not everybody may be involved in all phases. The system director of a county mental health agency may need to be involved in the adoption decision because they're going to partly pay for the implementation, but they may not have to be involved in learning to do the clinical model on the ground. And as I said earlier, in response to the person who wondered what are the costs across, we don't know yet that the multi-component implementation packages are the same for every model. For very simple kinds of interventions, you may not need to do all of these things. For complex interventions, you may need to do all of them, and they may be somewhat different by intervention. We just don't know the answers to those questions yet. The end of this presentation slides has references in which everything that I have in parentheses here and have referenced on the prior slides give you the full reference for articles that explain in much more detail than I can do here and now what I've presented, what these intervention strategies and components look like. I'll just briefly mention now that these that I have here focus on a combination of organizational factors within organizations that are trying to implement an evidence-based intervention and the external context and the actual day-to-day clinician implementation of something. And so the availability, responsiveness, continuity ARC intervention that Charles Glisson and his colleagues have developed is something that is used in and tailored to the particular evidence-based intervention an organization wants to use. He and I collaborated on a randomized trial of what happens when you use ARC and MST's standard implementation protocol. Do you get better outcomes by using just one, just the other, or both of them? Community development teams were originally developed here by the California Institute of Mental Health in California, underwent some refinement in preparation for a randomized trial that Patty Chamberlain and her colleagues are doing in many counties in California and Ohio. This is an approach to getting county agencies to collectively come together and look at, gee, what are the range of evidence-based practices we might want to use? How do we get the purveyor to come in? What can we do with our local knowledge to help support the implementation? Greg Ahrens is currently attempting something called an interagency collaborative team model in San Diego. And then there is a research review on the extent to which learning collaboratives could be part of this multi-component strategy. And to that point, I just want to say the evidence on learning collaboratives affecting practitioner behavior is currently very limited, meaning so far the well-designed studies suggest that there's, again, good camaraderie, but not a whole lot of translation into practice, but that research still has a long way to go. So I think everybody's probably signed off by now, and
actually, we have quite a few still on, and just a couple questions real quickly.
Yeah.
Are people going to be able to download the slides? I am letting everyone know that the session's being recorded and they can watch it again.
Yeah, I can. If I get them to you, Jennifer, can you get them to them?
Sure. Mm-hmm.
So I'm happy to do that.
Great. And then real quick, I'm not sure if you addressed this. Someone wanted to know, what can we do to change graduate education to get students to be more
Oh, yeah. Good question.
accepting?
So that person, may or may not be on the phone. So there are several efforts going underway. The clinical social work group, the name of which I'm forgetting, to change graduate clinical social work. There's a movement afoot in that field that's trying to get evidence-based interventions to be trained in graduate schools of clinical social work. The accreditation agencies that do some of this for psychology graduate programs are also in the process of building in requirements about being exposed to and trained in evidence-based treatments. Here in California, when Steve Mayberg was the mental health director at the state level, tried to collaborate with some of the graduate programs that train master's level marriage and family therapists. That's still a work in progress. So there's not a silver bullet, but there is awareness and there are efforts at the sort of regulation level to make sure that some more of that gets built in. But it's just, it's still in its early stages.
Thank you so much for being here with us today, Sonja. You really did a great job, and like I said, so many of our attendees were intently listening on everything you had to say. I'm just going to take a second and launch a poll, and if it shuts us out here in a minute, then not much is lost. So bear with me for a moment, everyone, and please take a minute to answer the poll that will be coming across your screen here. Okay, we have 100% of our attendees letting us know that the material presented today was interesting to them. And just a few more questions. Wanting to know if people are interested in learning more about this topic. And we'll get those results here in a minute. We have a great majority saying that they would like to know more about this topic in the future. And two more real quick. We'd like to know if this information will be useful in your work.
Is that a question for...
Sorry, not for you, for our attendees.
Sorry.
I know, I thought that same thing as soon as I said it. Wow. 100% are saying, yes, absolutely, will this be useful in their work? And lastly, we'd like to know if the information was well presented, but I think I can already know how that's going to pan out. You did a great job, Sonja, and thank you so much again for being here. And as these results are rolling in, yep, the information was well presented, and everyone's just so pleased. And like I said, we had record-breaking attendees for this webinar, so that was very exciting, and thank you so much for helping us make that happen. That's it. Please join us next month. It's on our next webinar is yet to be determined, but it will be on the third Friday of the month, 9 a.m. Pacific time, and we will see you then. Thank you.